And thank you very much, Winnie and Nick, for the invitation to speak this morning. Should drops be our first-line treatment? Well, we've heard a pretty good, fairly devastating analysis of one of the components of many of the drops on the market today. Some of the limitations of medications and topical medications extend beyond that. And I'm going to try and cover some of the alternatives and some of the things that I think we should be thinking about when we're making that decision. I've got some competing interests because I'm running a trial comparing primary laser treatment with drops, so I have a particular interest in trying to answer that question. The trial hasn't completed yet, so I don't have the answers. So I still don't have that evidence to confuse us. I'm going to kick off with a grandmother rule. In fact, in this case, it's a great-grandmother rule. And I say to the residents, and as I'm sure most, if well, not all of the people here do, think what you would be doing for this patient, for this pathology, in this situation. What would you do if that were your grandmother, mother, or, God forbid, yourself? What would it be that you would want? And every now and again, the residents come up with, well, I'd want this. So, okay, well, why are you doing that? And often it's just a nice, simple way to focus our minds on what it is that we would want in that same situation. And sometimes that diverges from what it is that we're actually doing because of habit, because of limitations of service provision, because of other limitations on what we're able to offer. And I think it's a very nice way of just refocusing how we're thinking about our options and what it is that we're offering to those individuals. And we'll come back to Berta. What's wrong with medical treatment? We've had a pretty good assassination of preserved, or at least back-preserved medications. And yet, many of us knew much of that, if not the science. We knew some of the principles of that, and yet we persist in using medications. We should probably be saying, what's right with medications? Well, when they work, when medication works, it works well. We know that there are profound reductions in intraocular pressure from available medications on the market now that we could not achieve 30 or 40 years ago, that are preventing a large number of individuals from needing surgery. And although we've got 90,000 patients going through the glaucoma clinic, there's very little increase in the number of surgical procedures that are being done at Moorfields compared to 10 or even 20 years ago. So there's a huge increase in the number of diagnosed patients, but a very small increase, if any, in the number of surgical procedures required. So clearly medication is achieving something. But it's got problems. The main barriers are about compliance. And compliance isn't only about itchy, burny eyes and benzalkonium chloride. Simple forgetfulness and complex dosage schedules, as well as those local side effects, reduce the compliance, the persistence in use, or the concordance, if you like. We also have the reduced surgical success rate and intrinsic non-responder rates. There are a number of individuals that just simply don't respond. It's hard to pick out those, obviously, from the ones who aren't using the drugs, because people rarely tell us which and how often they're using the drugs truthfully. There's lots of evidence, there's a lot of concealment of non-compliance. And then, of course, other issues of tachyphylaxis and also cost. If we're going to withdraw slightly and take a slightly broader view from just the grandmother rule and think about a population-based level, we've got much more clearly to think about cost and what it is that we can afford. So we should probably be saying, well, what is it that we can do as an alternative? Because there's lots of data that people don't use the drugs we give them. I mean, this is American data, so it's confounded by cost and the cost to the individual in the States. But it's a very nice study from Dave Friedman's group, just showing that an awful lot of people either stop using or are forced to switch from what it is that they were given very, very rapidly within the first year, and only a small number of individuals still using what it is that they were prescribed. So what are the alternatives? Well, we're going to hear about different drug deliveries later on this morning. I'm going to touch briefly on that. We can fire lasers at the trabecular meshwork, hopefully in an intelligent way that works for some people. And then there is also, of course, early surgery. What are we aiming to achieve for what patients with these? Well, I'm talking about open-angle glaucomas and ocular hypertensions because we've clearly got a totally different treatment paradigm for angle closure and possibly for secondaries as well. Early surgery is in brackets here because the TAGS trial has not yet, is still recruiting and is not yet reported, but is going to readdress that question with modern medications in great detail and will tell us for which of our severe patients we may want to simply cut straight to surgical intervention. And trabeculoplasty is the subject of the LIGHT trial, and I will not argue for it, but I will argue about some of the questions that we should be asking ourselves if we are not at least offering it to some of our patients as first line. So I don't want to be an advocate for it because we don't have the evidence from the study yet, but I will at least try and justify the reasons for why we're doing the study and the questions that we ought to be asking ourselves. So just to deal with drug delivery first, what's been tried in the past, there's a whole range of things that's been looked at, been tested, and none of them are actually in regular use, at least in our practice. Whether it's drug-eluting contact lenses, collagen shields, things that you can stick into the inferior fornix, punctal plugs that you can stick into the puncta with drugs within those. There are a lot more things on the horizon and being investigated now, some of those in phase 3 trials, still not regularly available, certainly down in South London in Tooting and Moorfields South, but liposomal drug delivery to increase drug retention on the ocular surface, subconjunctival injections in a variety of different forms, intravitreal injections, and also intracameral anterior segment injections so that glaucoma surgeons can get on the ocular drug delivery bandwagon. As yet, we have to wait and see which of those are going to be acceptable to patients, which of those we may be able to afford. But until then, one of the few alternatives we've got for primary treatment, notwithstanding that most of us are not currently using surgery for anything other than perhaps very advanced glaucoma in those individuals who really aren't going to take their drops, is selective laser trabeculoplasty. And we know that that has 100% compliance because we know who we fired lasers at. Now, it may not work for everyone, but if after laser you can still go on to use your medications and your drops and you can go on to do what we're currently doing, potentially without any downside, then perhaps we should be doing that for everyone because we may save a number of individuals for a number of years' worth of medications. And we saw argon laser trabeculoplasties were very destructive with large cratering defects in the trabecular meshwork, whereas lower level selective laser trabeculoplasty produces much less effect on the trabecular meshwork. There's a good sound hypothesis with a lot of experimental evidence supporting that, with stimulating short-term cytokine release and recruitment of monocyte macrophages into the trabecular meshwork with changes in Schlemm's canal conductivity and ultimately long-term changes in the cellularity. It is hypothesized long-term change in the cellularity of the trabecular meshwork. And Sheng's group showed very nicely that there was a true increase out to 3 months of the tonographic outflow, so it's not just some inflammatory mediated changes in aqueous production. And that translates in a number of relatively small studies to a reduction in intraocular pressure in the relatively short term. So most of the studies are 1 or 2 years. They're relatively small numbers, and in terms of study construction, they're not always the most robust of randomized controlled trials. And some of these claim spectacularly high response rates. That's not always our experience in practice because a lot of us were using SLT not as primary treatment, but using it in individuals who were already on medication, and anything that's used as second or third line has less bang for your buck, as we know from whatever we give to people. Even if you give them topical carbonic anhydrase inhibitors as first line treatment, you can get quite profound reductions in intraocular pressure. So whatever we're using first may well be giving us a decent reduction in pressure. So if we could use laser first and postpone the need for poor compliance and all of those difficulties we have, maybe we would be sort of one step ahead of the game, at least defer the need for drugs. But the question, is it worth the expenditure? Is it going to be worth doing this? That's less of a grandmother level question and more of a population question. If you've got 100,000 grandmothers that we're trying to decide what we're going to treat and what we're going to decide to do, then it suddenly becomes a very important question, how much is this going to cost? And then that becomes the real nub of the matter. Models show that SLT is less costly, but these are generally models, and there's very little direct evidence. So Cindy Hutnick showed that with proposed retreatments and some appropriate modelling of multiple drug use and costs in one particular system in Canada, that you could show that multiple therapy medications are clearly more expensive. and more complicated, more elaborate models looking at 5-year cumulative costs and modelling different forms of treatment showed that trabeculoplasty came out well. And in another way of looking at it, how long do you have to treat these individuals with just these forms of therapy until you get to an equivalent level of cost between 1 and just over 3 years, depending, of course, on the cost of the medications. And obviously, this is going to be exquisitely sensitive to whether things are coming off patent and how much the healthcare system is going to have to pay for them. More recently, and with a slightly more elaborate study, a 60-year-old mild glaucoma patient as the starting point, and then modelling how that group of example patients then progress over the ensuing decades, comparing prostaglandins with laser and considering 5 different stages of disease in a particular Markov model, such that you could progress from mild right the way through to severe disease, and of course a proportion of these patients are going to die on the way through. So you have a proportion of patients starting off at very mild disease at 100% and then going through over a period of time with an increasing proportion lost to death and an increasing proportion progressing through the stages of disease at rates of conversion of disease that are supported by evidence and supported by evidence looking at treated patients. And that suggested that realistic adherence rates would reduce the cost effectiveness of medication such that SLT became a more cost-effective proposal. So, should we be using drops as first-line treatment? Well, I'm going to duck the question on the severe disease because I think we should wait for tags. I think that's going to be a very, very individualised question and a very individualised question until we have that evidence, because it's going to depend an awful lot on that particular surgeon and that particular patient. But for mild to moderate glaucoma and ocular hypertension, the LIGHT trial is looking at whether or not we should start with laser. And the same caveat applies. We could wait for the results of this study to come out. But when you talk to people, an awful lot of individuals who are prescribing medications or doing laser would say, oh, I'd have laser first. So how many of your patients are you giving laser to first? Oh, well, in the NHS, probably, Well, why is that different? So my proposal is that we go back and ask ourselves, what is it that we're going to want if in 5 years' time our precious need treating? What is it that we're going to want, and what is the grandmother rule going to tell us? There are thanks to a large number of individuals who have made possible the recruitment into the LIGHT study. We've finished recruitment now, so thanks to those of you in the audience who've helped and participated. We've got 6 centres, we've got 3 years follow-up to go now, so we've got realistically, probably 3.5 years to wait for the answer to come out. But in those 3.5 years, we're going to be treating an awful lot of patients and potentially exposing an awful lot of patients to benzalkonium chloride. So I think we've got to answer this question in an absence of fundamental evidence and just decide what we are going to do for those patients. And in answer to our question, should drops be used for first-line treatment? I would propose probably not, probably because we don't have the answer to that trial. And probably we should be starting off with something which may not work for everyone. It may not work all of the time, and it may not work forever. In the majority of patients, you see a rise in pressure later on. But if we can save them from a year or 2 of medication exposure, then it's probably worth it. I'm just going to finish with the results of the focus group that we did for another grant application for looking at a surgical MIGS trial, which was to ask a group of individuals taking medications, taking drops, some of whom had had surgery, what level of risk for a surgical procedure, what level of risk would you tolerate? And with this level of risk, what percentage of success simply to get off medications, but with this equivalent level of intraocular pressure control, would you tolerate? So you're having cataract surgery, do you want me to do this extra procedure for you? And they said that if I had a 10% chance of getting rid of my drops, even in the context of significant surgical risk, that they would take that in order to get rid of medications. So my main proposal today is that we underestimate the impact and the burden, very much as our first speaker suggested, of medical treatment, not simply in terms of itchy, burny eyes and long eyelashes and orbital fat atrophy and possibly impotence from beta blockers, and that long list of problems. But I think we underestimate the impact of medications on our patients because we don't ask and possibly because we don't listen. So there's a proposal, and we'll have to wait 3 years for what will hopefully be a definitive answer. And I look forward to the questions at the end. Thank you.